Well, I wanted to welcome everybody to the final episode of It's a Brain Thing. We've been doing this for about 2.5 years now, and this is probably the last one we'll do. We covered most of the main topics that I wanted to cover. I'm not saying I'll never do it again, but at this point it won't be the monthly thing throughout the year that it's been, and I'm going to take a little break. So thank you all for coming tonight. I'm very pleased to welcome a good friend of mine and a colleague, Dr. Dalton, who is a clinical psychologist. We worked together for about 3 years, I think, saw a lot of patients together, and she has some expertise in the area of eating disorders, which is going to be our topic for this evening. So without further ado, I'll turn the mic over to Dr. Dalton, and she'll entertain us. Entertain, that's right.
What I thought I would do tonight was I thought I would go through first the criteria of the 3 main eating disorders, and just kind of go through the criteria at first, and then I'll sort of talk about what they really look like, and I'll answer questions whenever you want to answer. It'll be much more interesting if you ask questions. But I have lots and lots of information I could talk about. People who know me can tell you that I could talk forever about anything, but I will try to make it relevant, and if you have questions, it really is whatever you guys want it to be. So the 3 main topics I'm going to talk about would be anorexia, bulimia, and then binge eating disorder, which is also known as compulsive overeating. So I'm going to start off with anorexia, and I'm going to read from some of the criteria to make sure that I get it specifically right. Sorry, that's kind of boring, but I will talk more in general later. All right, starting with the anorexia nervosa, you have to have a very specific criterion to meet this particular diagnosis. And the first one is a refusal to maintain body weight at or above the minimal normal weight for age and height, and that's 85% or more. And to give an example of that is, say if someone's like about 5 foot tall, this should be about 100 pounds. And so if they're 85 pounds or lower, that's significant. That meets that criteria. It could also mean with adolescents that they don't meet the expected weight gain as they're going through their aging. Second criteria is intense fear of weight gain or becoming fat, even though they are specifically underweight. Third criteria would be disturbance in the way in which one's body shape is experienced, undue influence of the body shape on their self-esteem or self-evaluation, and then the denial of how underweight they are. They're usually in sort of shock about how underweight. And then finally, for post-menarchal females, which basically means once they've had the period, if they stop, their body stops letting them have their period because they aren't producing enough nutrients to maintain that. And that really needs to be at least 3 missed cycles for that to meet that criteria. And it doesn't count. It doesn't count if their period only comes back because they're taking like birth control pills or something like that. And then there's 2 specific types within anorexia. There's the restricting type, and then there's the binge purge type. And it's kind of just like it sounds. The restricting type are the type that simply just don't eat, and they do not engage in any binging, purging, or what we call compensatory behaviors to lose weight. And the second type is just like it sounds. But it doesn't have to be specifically binge and purge, but they often use things like laxatives, diuretics, or enemas, which, boy, that's some interesting treatment, let me tell you, when we're doing that one. There's separate issues that go with that. And basically, really for all 3 of these disorders I'm going to talk about, the age of onset is most common in, it used to be middle adolescence to early adulthood, and now we're seeing a trend where it's shifting to early adolescence and even pre-puberty. So we'll talk about that here later. Prognosis for, particularly with anorexia, is the earlier they get into treatment, the better. And the earlier stages of treatment is actually pretty good prognosis. The longer it goes on, especially the longer it goes on untreated, the worse the prognosis becomes. Moving on, any questions so far? Okay. Moving on to bulimia. Recurrent episodes of binge eating. This is one that requires binge eating. And a specific description of that is eating in a discrete period of time. It's usually within a 2-hour period, amounts of food that are definitely larger than what you would normally eat, or under different circumstances than what you would normally eat. And then a lack of control, excuse me, a lack of control over what you feel like you're eating. They really describe a sense of completely losing control during the binge. And it has to be, goes along with recurrent inappropriate compensatory behaviors. So such things as, we talked about before with the binge purge, vomiting, excessive exercise, laxatives, diuretics. And that has to happen at least twice a week for 3 months to meet the criteria. And again, the same thing with anorexia, their body image and how they perceive themselves has an undue amount of influence in their self-esteem and their evaluation. That's an additional criteria. And it can't happen just in the course of an anorexic episode. So that makes it distinct. And then this one has the purging type, because not all bulimics make themselves sick. There are some that do not do that, and they would be listing as a non-purging type, and there are, of course, those that do. The primary distinction between anorexia and bulimia that gets really confusing for a lot of people, and honestly there's a lot of overlap, is that the refusal to maintain the body weight, and bulimics frequently look average size and sometimes even mildly to moderately even overweight. So you can tell some difference with that. And bulimics aren't what they would say. They're not good at going long periods of time without eating. And so we'll get to that a little bit later. And again, like I said, the time for it to start the onset, again, is starting earlier and earlier. And we're seeing in the last decade, there's some research that's supporting that it's starting by the time in late elementary school. Whereas before we were looking at middle school and early high school. And then the third category I'll be talking about tonight is binge eating disorder. And this is recurrent episodes of binge eating, just like what we discussed before. Eating in a discrete period of time, about 2 hours, eating more than you would normally eat, or eating secretively in the sense of lack of control during that time. And then the second criteria is binge eating episodes are associated with 3 or more of these following criteria. Eating more rapidly than normal, eating past the point of being uncomfortably full, large amounts of food even when you're not physically hungry, eating alone because of embarrassment about how much they're eating, and then it's usually followed with a disgust of oneself, depressed, and even excessive guilt after they finished eating. They have to obviously be upset about it, which I always think is a funny criteria because by definition that's what a mental health diagnosis is. It's upsetting, and it has to last at least 2 days a week for 6 months. And it does not come in addition with any compensatory behaviors like the vomiting, excessive exercising, any of those kind of behaviors. It doesn't come with that. It's just simply the binging. And I think probably the most important thing for me to say first about binge eating disorder is it is probably, actually, not probably, it is definitely the most common of the eating disorders. And they think anywhere as much as 3.5% of women and at least 2% of men will engage in this at some point in time in their life. And that's actually pretty high when you consider anorexia is closer to maybe 0.5 to up to 1.5% in a lifetime, and bulimia is 1 to up to 3% in a lifetime. And the male to female ratio is actually kind of makes sense. It's 1 male for every 6 females with anorexia, and 1 male to every 10 females with bulimia. But they think that, actually all the research isn't in, but they think that with binge eating disorder it's probably comparable. There are probably just as many men who do it in some form, but that they're not coming into treatment and aren't reporting it. But I imagine it's probably still closer to a 1 to 2 ratio, 1 male to every 2, but it's much higher than what we first anticipated. And it's only, I think, in the latest updated model of our treatment manual that we really even consider it a true diagnosis. It wasn't, before it was one of the things that they were looking at, but they didn't think that it was real. And I think part of the reason now that we're seeing it more and more is that the bariatric surgery has been approved by more and more insurances. And so people are coming into treatment for that. And I don't know if you guys know much about that particular type of surgery, but you have to have a psychological evaluation to prove that your mental health is okay to have that surgery. Or otherwise you could have some potentially damaging recovery efforts. So that's the criteria. Are there any questions? It's kind of confusing because a lot of it overlaps, but basically what you want to really remember is that anorexics is the refusal to maintain the appropriate weight, the excessive fear and terror about weight gain, whereas bulimics certainly don't want to, but they don't have what would be listed as almost a phobic type quality. And in my experience with working with them is that it can even take almost what we would call a delusional quality. When they would look in the mirror, they look kind of psychotic because they will look at me. I mean, I will have people that are, I mean, it's beyond seeing the ribs. I mean, you can see the ribs through their shirt, not just like the, and they will look in that mirror and they'll say, gosh, look at that belly. I can't take it, take the mirror away. And we will have them do exercises where we would have them like take a rope, take a piece of string and have them pull out about how much that they think it would take for them to wrap it around their leg. And they will take like the size it would go around a horse. I mean, it would be an enormous amount. And they're shocked when I make them do it on their body that it loops and loops around. Their perception reaches almost what we'd kind of consider a psychotic type of level, and that it's really not listed among a psychotic disorder. So it also takes on the quality of obsessive compulsive traits. A lot of their routines that involve food for anorexic sound very obsessive compulsive. They have very specific, rigid routines where they are, in their mind, they're required to chew so many times on one side, and then chew so many on the other side, and then they're allowed to swallow, or they will spend, the anorexics will be spending all day obsessing about what they're not going to eat. The bulimics, for the most part, will be spending all day deciding what they're going to binge on. That's kind of a distinction to sort of remember. But in either case, and as well as with the binge eating disorder as well, but they spend all day about what they're going to binge on and how they're going to do it. And they all avoid activities that involve food, if at all possible. But they all have qualities that are very specific for us to look for in mental health, and that is that they almost never want to come in to mental health. That's, you can just about guarantee, specifically with the anorexia, it's the worst. Bulimics frequently are aware that they have a problem, but they don't want to come in. And I have to say that whenever I treat a lot of adolescents, I'm afraid, which is why I am developing such an expertise in this area. It started with my year of work at Virginia Tech, where I did research for them for a while, and it's rampant on campuses. I could guarantee, just as an aside, a diagnosis of an eating disordered client if they came in with a group of girls. They never came in by themselves. It was like the whole sorority was coming in, forcing somebody to come in. It was never like a solitary kind of thing. They always had a handful of girls would be coming in, confronting. And when I ask, as a standard part of our intake for any client, when I ask them any history or concerns of eating disorders, or what I would call disordered eating, which I'm going to get to here in a second, it's very disturbing what most of the adolescents tell me who don't have a problem. They don't say, well, no, goodness, that's awful, or I couldn't do that, or vomiting is gross, or they'll say, no, I'm not strong enough to do it. They don't say that's a bad thing. They say, I don't have the willpower to do that. So it's even kind of glorified, which is a real concerning thing. And I almost never do groups with anorexics because there's a huge competitive factor. Most anorexics and quite a few bulimics, their individuals are very perfectionistic. They work very hard to meet other people's needs. They're really good at taking care of other people. They're often really good about cooking, but not eating what they cook, and they always talk about how they nibble as they go through, but if you watch them, they don't nibble. But that's what people say. But they have high competitive drives. They're often valedictorians in school, athletes, especially before it gets to the point where it requires such intense treatment. They're often very good students, and they often go into very highly driven and performance-driven careers. And I will get into here in a little bit about some factors that might be contributing to the causes to it. But one of the things that I probably end up diagnosing the most is eating disorder NOS, meaning not otherwise specified, because they are probably anorexics that haven't met that 85% weight issue. They are well on their way. They are doing incredibly dangerous behaviors, and what I talk about is disordered eating. But they haven't lost so much weight that they've reached the dangerous level yet. But that one criteria stops it from truly being anorexia, but it is, in my opinion. Treatment doesn't change, except that I probably don't have to hospitalize them. Let's see, what else do you guys want? Any questions so far? Like I said, I keep rambling. Okay.
I have one question. If it's not, maybe you're going to discuss it later, but the binge eating and the binge eating disorder and bulimia. Mm-hmm. So the main difference then is that they both binge, but the one group usually almost always does the purging where they vomit, force themselves to vomit,
yeah.
Or
in order for it to be binge eating disorder, there is no what we call compensatory behaviors.
Yeah, okay.
They don't engage in any excessive exercises. And by excessive exercise, I mean 2 to 3 hours a day is not unusual. Them running 5, 10, 15 miles a day is not unusual. But in binge eating disorder, there's no compensatory behavior. There's no vomiting, no diuretics, no laxatives, no excessive dieting,
So is their body image then different? Because the bulimics then, obviously they do the purging because they feel like they're getting fat from all the stuff that they ate, right? Whereas the binge eating disorder people, they're not doing any kind of behavior to, are they not as worried about getting heavy, or are they still worried, they just don't have the...
Actually, they tend to be much more depressed and much more isolating. Most of their behaviors involve eating completely isolated. They will be the type of people that would go through like the drive-through, order a lot, and they might even talk about their ordering for the family, and then they'll go in some parking lot and eat it.
So are they heavy people too?
Almost always. Almost always. Especially if you think about the criteria, it has to last 2 times a week for 6 months, that they're eating very abnormal amounts of food, and they don't vomit it up, they don't get rid of it. And if you're doing that for 6 months, you're going to gain a lot of weight. But most of these people that I have treated have been coming in relative to getting the bariatric surgery. And I think my heaviest was 792 pounds. Now, granted, he was 6 foot something. 6'5" or more. But it was very, very large.
Yeah.
And when you're doing treatment consideration, you also have to be prepared for having the type of facility where these individuals can come in, where they would have chairs that they could sit in, and a facility that can maintain them. And the medical community is making a shift in that direction to accommodate these people. But insurance companies have finally kind of grasped the concept that if we can get these people healthy enough psychologically, that they can then qualify for the medical treatment. Their risk of having medical problems goes down astronomically. But they really do have to pass a psychological evaluation, or they will harm themselves post-surgery. And we have to, of course, one of the reasons that they're coming in is we have to rule out that they don't have anorexia or bulimia, which anorexia is kind of a given. They don't have that one. But bulimia, because they really will, if they have a binge eating disorder, they will rupture their stomach, their esophagus, and have horrific problems. And there are some people that can kind of fool some of the psychological tests and can make it through, and then they come into us post-treatment, post-surgery for treatment for it. But I treat both ends of the spectrum, and it's certainly not all of my clientele, but it has been very difficult, and I'm working with my staff to make sure that they are aware of this, that I cannot have my anorexic clients waiting in the waiting area as some of my clients that are coming in for the surgery evaluation, walking through, because they are just simply terrified of weight gain, and when they see someone like that, they see a mirror image of themselves, or what they could be if they do what I ask them to do by making it up to 500 calories, for the next day. It is not unusual for me to be working with anorexics that are having 20-calorie days for several days in a row. They are aware. They honestly can tell me how many calories is in the stick of gum and which brands of gum. And that's their caloric intake for the day. And what is often very disturbing to me is treatment involves working sort of with a team approach. I try to send them to a dietitian, which frequently they don't want to go to. I always send them and make it a requirement for them to work with their family practitioner to do all sorts of blood tests to make sure that there are things that are okay with their heart and their blood panels that are beyond the scope of my practice. But what's very disturbing to me is when things come back pretty normal, and I'm looking at this person in front of me who is clearly anorexic. They meet that criteria of only being at 85% of their weight or less. And they, at the very least, should be severely dehydrated. But our body is pretty fascinating. It takes care of us, and it adapts after a certain amount of time. And I'm always really disappointed because I want to be able to use it as ammunition to scare the person about how much trouble they're in. And then it fails because their body's adapted. They did a study, and I'm going to butcher it up, so I apologize for people who want to go look it up online, but it was done in Minnesota, and I won't even call it like the Minnesota study that is referred to in a lot of the eating disorder literature. Following World War II in the 1950s, some researchers in Minnesota wanted to take a look at what that kind of weight loss did to the folks in the concentration camps and how it was going to impact them psychologically, and they wanted to take a look. And so they had a little trouble recruiting some volunteers because they had to lose something like 20% of their body fat in a very brief period of time to mimic what happened to the survivors at Auschwitz. And they got a group of Quaker men volunteered. And I want to say it was something like 75 men, but again, I apologize for the specifics on the details. And these were pretty manly men. Quakers, by my understanding, are pacifists, but they're definitely very manly men. They didn't do cooking, they didn't do cleaning. Their part of their world, especially in the 50s, was very work-oriented, but they had to come in, and they were pretty much starved them systematically. And over the course of, I want to say it was 3 months, they started developing some very strange traits. These men became completely obsessive-compulsive about any number of things, including recipes. They would spend all day obsessing about food. They would become very meticulous about how they ate their meals, how they did things, and they did nothing but talk about food and cooking and shopping and how to grow things so that they might taste a little bit better. But I mean, they became completely obsessive about it. They weren't quite prepared for that part of the study. And they even followed up with these men, I want to say, 10, 15, 20 years later, and when they had returned back to their normal body weight, and they were still different when it came to food. It does something to your brain on a fundamental level that I'm not sure that we understand, that changes them. And so I almost never give a separate diagnosis of obsessive-compulsive disorder unless their obsessive-compulsive traits predate their eating disorder, because they become very obsessive-compulsive relative to the food when it involves particularly anorexia, but I see it frequently with bulimia. So now I'm going to move on. Unless you guys have some more questions.
Well, I don't want to derail it too much, but you're mentioning obsessive-compulsive. We're talking here about obsessive-compulsive disorder and obsessive-compulsive personality disorder, and the difference, and when you were describing anorexia, and of course the patients that we've seen together, they sort of seem very OCPD, very perfectionistic, and not so much like OCD. And so it's interesting. I wonder what these folks in Minnesota, whether it was more like OCD, where they have the intrusive thoughts and all the time thinking about food and all this stuff. That's intrusive, irrational thoughts, or was it more? I just wonder how the brain changed.
Well, I do believe it was a change, though.
Yeah.
So when I was first trying to learn a little bit more about this, while I was in Virginia Tech, I was asking a lot of questions about what we call premorbid functioning before they really started developing some of these symptoms. And they didn't describe obsessive types of thought process prior. They were driven, so we certainly might listen with what we call a type A personality, which is sort of kind of a made-up term. But that driven type of personality, they had that. The perfectionistic issues were there, but they didn't have the obsessive quality about it. The competitive drive was there, but I never, for the handful of clients that I'm thinking of, I didn't see it before. But it definitely is a part of their trait, I think, afterwards. People that I have worked with that are coming in treatment for something else, or maybe sort of a maintenance regimen, and it's been 15, 20 years since they've had a true episode of anorexia, they admit that it changed them. The difficult problem, I guess, to kind of sort through that is that a lot of these people who are developing disorder are developing it during their adolescence, at a time when they would be developing personality traits anyway. So I guess it's sort of chicken and the egg question, which came first, I don't know. But it's probably a good research question. I bet there's somebody out there who might be watching us today who might know. And if so, feel free to respond back.
That's right.
It's a great All right, I'm going to move on to some things that I think are probably a little more relevant for people who might be wondering about some individuals in their world or questions for themselves. I'm going to move on to some things that I've observed in treatment that might not be something you could find in journals everywhere, but I'm seeing over and over again, as well as some things to be looking for that are supported. Some statistics about anorexia that I think is probably pretty important to think about. I remember being shocked by this initially before I started working with a lot of them. It is probably the highest mortality rate of any mental health illness. And I was shocked by that because when I started, I used to work with some chronically mentally ill population, and I would think about some schizophrenics that had very poor health and or impulsive behaviors, and or bipolar folks that could harm themselves very easily. But actually, especially if you look at the population of anorexics who have been hospitalized for their anorexia, the average is about 10% of them will end up dying from complications of their illness. 10% is a huge number. And it's something that constantly floors me, because as I will talk about probably at the end of the talk, is that insurance companies do not like to pay for it, which floors me because we're talking about a 10% mortality rate with this for a severe diagnosis. So it's very high death rate. And again, it's the complications with the illness often having to do with heart arrhythmias and perhaps some of their compensatory behaviors like Ipecac. I never say that right. Is that right? Ipecac?
Ipecac. Yeah, that's good, yeah.
That makes them inducing vomiting. And laxatives, which For anybody out there who's watching, it is not an effective weight loss measure. Your body has already absorbed calories. Stop it. Besides the fact that it interrupts my treatment on a regular basis because they have to take off running out of the room. And that their body will actually stop, their bowels will stop moving appropriately. And they get into a condition where they can't go to the bathroom without it. And it causes lots and lots of issues that are medical and that I can't even explain very well. But it doesn't work, so quit. Okay. Anybody who's treated anyone with eating disorders or has known anyone or has struggled themselves, it's not about food. Food becomes the symptom, that becomes a problem of its own. It's almost always about control in some form or another. Oftentimes it started off as a coping skill. They feel like there's some aspect of the world that they cannot control, and they can't control what goes in or comes out of their body in this manner, and it gives them a sense of control. And for those that are striving hard for this perfectionistic, they have this almost a euphoric high that comes from being able to control their weight in that manner, to overcoming their hunger, that battle, that eternal battle. It gives them an enormous sense of control. But the very disappointing and painful thing is that they will rapidly lose control if they use this as a coping skill. And so it's a very short-lived cycle, or short-lived positive effect that they get before it becomes a very negative cycle that can become lifelong if they don't get treatment. But it's really always about control. If you talk with anybody who's ever had this illness or has known anyone. And there is research that supports, when people always ask me, what causes this? What causes this? Well, I mean, causal type of language is not what we use in mental health or medicine for the most part. We talk about correlation. But basically what causes it is what people always want to know. So I'm going to be cautious to say these aren't causes, but these are things that we're definitely seeing connections to. They cannot deny any longer that there does seem to be, for many people, a biological connection. Frequently we find first and second degree relatives have struggled with this. And oftentimes when the client is sitting in my office, and it's the teenager, and I ask, is there a family history of this? And the kid says no, and the mom says, oh yeah. And the kid's shocked. So it's not even like they know this. It's not behavior that they're witnessing and mimicking. Or, yeah, grandma did, or my sister does, or her cousin does, or actually her dad talked about it in college. He had, and it's often, so we kind of have to start to wonder about a biological connection that they didn't really consider back in the 70s and 80s when they were first looking at it. The other thing that I have read in recent years that confirms what I've seen in therapy about related issues is I can't think of a time when I have ever treated someone where there was not a case of a family member, almost always a parent, that was either way over-involved in their world or way under-involved. So there was a parent that, at least from the person's perspective, I say that from the teenager's perspective, and all teenagers think their parents are in their business far too much, but this goes to extreme. And I can't think of a single time when I have treated someone where there wasn't a parent that was so invested in their child and living through their child, or was so worried about their child, and it was almost always good intentions. I can't think of a time when there was a parent that was intending to harm their child. It was good intentions, paving the road to hell, as we talk about it in treatment. They're meaning well, and it's having an unintentional side effect. Or on the flip side, there is a parent who is missing, or is uninvolved or emotionally completely disconnected. I'd have to say probably the most frequent thing that I've seen with that is a parent in jail or drug use. Or they were given up for adoption and they know it, and they've spent a big chunk of their life thinking about that. So there seems to be something in terms of the home environment that is very much involved, and it usually becomes an aspect of our therapy at some point. Do you have any questions so far? I saw some looks out there when I said that, so maybe that was a little surprising. And it's not to say that we're going to be blaming the family. We don't ever talk about blame. There are times, in my therapy, at least in my approach, I don't use the words like blame and fault. Those are very shame-based words, and this is a very shame-based illness. All three of these things are, and so it's really not helpful to look at it from that perspective. And I find that so much of the family try to use emotional blackmail to get them to eat or to stop their behaviors, so it's like repeating the cycle all over again. But what I do talk about is taking responsibility. And so there are times where I have to kind of call on the parent and say, okay, we need to take a step back and take a look at what's going on in the family. And so we do some family therapy. And it's more difficult with anorexic because they're almost always very angry about being in my office. Even admitting about coming to a therapist means they're losing control. An additional factor that we use into the dietitian and talking with a family doctor about getting blood work and making sure that's maintained is that I almost always refer them to the psychiatrist to have an opportunity to talk with them about antidepressants, because there's some good research about how that will help them. And I almost always have difficulty getting them to do that, because that again is about giving up control in some way, and not to mention the fact that they have to swallow something, and that they're worried about the calories. I can't get them to take vitamins, especially like the children's chewable, because you read on the back it's got 30 calories. That's their whole day's worth of shot, for some of these folks. And so we have to start pretty basic. And for the individuals that I cannot get to eat, or that refuse to allow me to weigh them, they do have to go to a different type of facility, which is often an inpatient or an intensive outpatient therapy center where they do nothing but treat those. And the inpatient ones that involve hospitalizations really are primarily just about getting them to eat, and then they come back out into treatment. They always deny that anything's wrong anyway, so it's not unusual whatsoever for me to have somebody come into therapy based on as a family member, and it comes out that what they're really here is for this, and the kid doesn't know it either. And so they set them up in my office to tell them for the first time that they're coming in, because we think you have an eating disorder. That's not helpful. Please don't do that. That sets us all up to fail, and the kid's mad. And I'm not going to stop them from leaving the office. So. But I wanted to go through some signs of what to look for. And a lot of these signs are going to be, especially mental health related signs, are going to be overlapping. So I apologize for the repetition, but it's something to keep in mind. So signs and symptoms for anorexia include noticeable weight loss, becoming withdrawn, excessive exercise, fatigue, always being cold. That's one to really pay attention to, because it has to do not just with loss of body fat, but some other issues. Muscle weaknesses, obsession with food, calories, and recipes, becoming very, very rigid on their diets and only eating very specific things, and they will do it. Whereas most of us, like right now I'm not supposed to have dairy, because I'm trying to feed my child, and he can't have dairy. That's hard to do. And I'm doing it for the love of the child. And I see his face breaks out, and it's very sad. So I know I'm doing it when I'm doing it to him, and even that is still hard to do. But these individuals can do it, and they are very proud of their ability to stay on these restrictive diets and eat the 30-calorie days. They're proud of it, and I'm asking them to take that away. So it's a very difficult treatment process. Excuses for not eating meals. I'm not feeling well. I ate earlier. That's something to pay attention with your adolescents whose lives are very busy and they're going to this practice or that meeting or that activity, or that I ate at work, especially if they work in fast food, which a lot of them do, ironically enough. And you don't know whether they ate or not. So one of our treatments does involve sort of implementing a traditional family meal where people have to come and sit down, and at least the parent gets to see if they're not eating. Unusual eating habits, like I talked about before, like cutting food into pieces. We've had a particular individual that we treated a while back that had difficulty with giving herself permission to swallow the food. So she would just chew and chew and chew and then spit it out. So she got part of her hunger was satiated just by the taste of the food, but she wouldn't swallow it. Of course, that's something that's noticeable if you eat around people, so she wouldn't eat around people.